Okay, so I wear several hats at Northwestern. So I'm an ocular pathologist by training. I do comprehensive ophthalmology, but my areas that I have interest in are diabetes, healthcare disparities, and big data. But I'm also a pathologist, so what it usually means is I'm never in one place more than a day and a half per week. And so the other thing that I was asked to talk about was what I do as an ocular pathologist. And so so we're going to start with a quiz. Okay, this is your, and so what is the true, which of the following is true about eye pathology? Okay, residents view it as a necessary evil. So true, yes. It's a distant memory for most clinicians. True, for most, right? It's a required part of all residency programs. Yes, it is, right? So it makes each of us better clinicians when we understand it. So that's true, and that's my goal is there when I teach pathology and I practice it. I've been practicing it for many, many years, and I have yet to convince one of our residents to go into it, but I'm still trying after 20 years. But I'd like to think they all think of, they remember me saying something when they look at a cornea, or when they're looking at an OCT. Is that the RPE, or is it, or where is that? Or are we in the choroid? So, and the answer is all of the above. Okay, so when I was asked to talk about this, I'm trying to think, well, what do I want to tell a bunch of disparate physicians with disparate interest in the front and back of the eye? How can I make this interesting and relevant to all of you? And hopefully I'll do that. The one thing that I would say is that at any time you're thinking of a pathology specimen, is communication is important, okay? I hate getting pages in the middle of the day and I hear that beeping sound in the background from the OR, from the anesthesia machine saying, what should I do with this specimen? It's communicate beforehand, okay? Second thing is, don't withhold information. And I don't mean, I have, some providers that say, well, I don't want to bias you. I'm sending you a specimen, right? And when we think about that, how many times in medicine would we consult a general surgeon and say, I'm going to send this patient to you, but I'm not going to tell you why, right? What, how you present the information and what you present will help with the answer, okay? So please don't do that. And then knowing what either the histopathology or the clinical differential, okay? And when we submit specimens, knowing the exceptions, right? I think that's the thing that you have to know, like what, you don't want to have the conversation that, well, we have to get another specimen because I put it in the wrong, media, okay? And when in doubt, if you think, should or shouldn't I send this? If you ask yourself that question, send the specimen, okay? And we'll talk about those reasons why, okay? When you're a surgeon, you're thinking of a specimen you want to know, really basically, what's the diagnosis? But even more importantly, what should I do? Are the margins involved, or do we have to do anything next, okay? And what I hope to convince you by the time I'm done is that the answers to those questions are definitely affected by how you mark, label, handle, submit the specimen, okay? And so most, whenever you go into the OR, you have a plan, right? And you have contingencies. What am I going to do with this? And you should also, if you're going to send a specimen, you should also have a plan on what to do with that specimen, okay? So with the preoperative planning, most of them, probably 95+% will go into just formalin the way they always do. So that you don't even have to think, that's your plan and you're done, right? But some of them require special fixation and has to get your correct diagnosis, okay? And those are the ones we're going to talk about. And when in doubt, again, call the pathologist. If you've ever been to eye pathology, talk to clinicians, call the pathologist is in there probably at least 5 times in any of our presentations. But let's just talk about 3 examples. So lymphoma, ocular cicatricial pemphigoid, sebaceous cell carcinoma that may require special fixatives. Eyelid, here's a patient with an eyelid lesion where a biopsy was done. Now, and if you're thinking that this is lymphoid, it might be a salmon patch when you lift that and when you evert the lid. On the left-hand side is, this is routine histology, so this is just H&E. I would call that a lymphoid infiltrate. Those are relatively well differentiated lymphocytes, right? The middle one, without ancillary staining, I could probably tell you that that's lymphoma. The lymphocytes are larger, the chromatin is less clumped, there's mitoses in there, right? What about that one on the right? Is that lymphoid hyperplasia? Is that a well-differentiated, lymphoma? I don't know, right? And the gold standard for this is flow cytometry, okay? And flow cytometry, has to be done on fresh tissue, okay? So the minute you put that specimen in formalin, you lose your gold standard diagnosis, okay? And that's for lid, conj biopsies. The vitreous ones will be handled a little bit differently, but they require fresh tissue. Right? And what do you do with that? Well, you put a couple of things. One, you want to put it you keep it moist and send it. But you also want to communicate ahead of time so you know where that specimen is going and where somebody can, which lab they should bring it to. You also don't want to schedule these as your last case of the day because fresh tissue, basically the amount of cells just goes straight down the more it sits without being processed, okay? So, and with,
sorry.
There we go. Okay, we're back. Okay. If there's your specimen on top. Some of it's going to go to flow, and there we go. Some we'll basically take some fresh tissue, do flow cytometry, and then we'll also look at other things. We'll put it in formalin ourselves and look at H&E staining, and do some immunohistochemistry and sometimes some genetic staining to get you that answer. Okay, but you have to know to submit it fresh. Another one is ocular cicatricial pemphigoid, right? So you have conjunctival biopsies when you suspect ocular cicatricial pemphigoid. These are handled by different labs in different ways, okay? So you always want to know your lab there. And there are also different departments. Some of the dermatopathologists will do it, some surgical pathologists will do it, some of the eye pathologists will do it. The typical one is a media, so it's not fixed, it's put in a media. And we're going to talk about conj specimens in a bit, but you want to keep it flat so we can embed it on edge. If you forget that and you submit, just in formalin, all I'm going to tell you is that, yes, it's conj with inflammation and vascularization. And you're like, I knew the patient had a red eye to begin with. You're not really adding anything to this. And that's because we can't do the anti-basement membrane antibody staining on formalin fixed tissue. So you can see the nice linear subepithelial staining on direct fluorescent antibody staining. So what about sebaceous cell carcinoma, right? So sebaceous cell, we can almost always determine if it's sebaceous cell or not on routine. So you don't really need to get the stain or the OCAPS question that we all ask as well. What do we need to look at that? Oil red O stain will look at fat. Anytime you put specimen in formalin, the lipid dissolves between that and the processing. So oil red O, you would want to think about if you had an initial biopsy that said possible sebaceous and you're going to do a full excision afterwards, you might want to let us know ahead of time. We might process some of that differently and then put it, do regular processing so we can prove that it's sebaceous cell. But for the most part, we can do that on the formalin fixed tissue. Okay, so if you're doing any sort of biopsies, what are some potential pitfalls? Okay, this looks like a benign lesion. I'm not gonna send it because it looks benign, right? So and you're probably right, very high percentage of the time, but not 100%. This is another one. This is what crush artifact looks like. So when you take the forceps and you smash all the cells, so especially when you're doing very small biopsies, you just want to make sure that you're handling that tissue, very well. And then don't put multiple biopsies in the same jar. So oftentimes I'll have our people ask, well, I'm doing like 6 of them on different areas, right? Can I just put them all in the same jar? Like, you can, but you don't want to have the conversation. I've got 5 pieces of good news and 1 piece of not so good news. You got a basal cell somewhere, the other 5 are normal. And so that's what happens when you put multiple biopsies in the same jar. So just remember to put them, separately, okay? And here's an example of, a benign, cyst, 36-year-old. This came through our lab, and it's just an epidermal inclusion cyst, right? So very easy to look clinically, just a yellow, fleshy lesion on the eyelid. Here's another 36-year-old with a cystic eye lesion that looked very, very similar, okay, clinically, but when we looked at it, it's a cystic form of basal cell carcinoma. So that's why you have to, you should send the specimens that you remove, okay? So again, have your plan, knowing your special circumstances, okay, and convey, the appropriate information to us, because we can get you a better answer for that. There's my communication plug once again, right? So I just want to show you a couple of cases for lid biopsies before we move on. But here, a bump on the eyelid is probably the most common thing that we see in biopsy. The other is the itchy, red, burn, get out of my office, I got better things to do, type of patient, okay? So bump on the eyelid, Chalazion, right? This is a garden variety Chalazion. Here you've got a big lipid vacuole with some lipogranulomatous inflammation, next to it. So obviously, when we think of, a Chalazion, if it recurs, right, then those ones you definitely want to send, because the recurrent Chalazion is kind of the classic sebaceous cell carcinoma, right here, okay? So the other one I want to show you is, blepharal conjunctivitis. We all see it every day, all the time, and those patients, especially the chronic ones, can, sometimes be just very hard to manage and take more time than you think you might want to spend in that visit. But when they're unilateral, those are your tip-offs there. So the above one, blepharal conjunctivitis, or allergy, blepharitis. The bottom one, you see the thickening on that upper lid. Okay, and these are the ones that you might want to think about biopsying, because if you look on your left side, that's a normal eyelid margin, right? So thinly keratinized epithelium, 5 cell layers thick. As you go on the lid margin, you lose the layers, so you maybe go 2 or 3 cell layers thick, and then you lose a keratin when it becomes conjunctiva. But this is an example of the other type of sebaceous cell carcinoma, which is not a bump, right? And which I think that it is one of the hardest ones to diagnose and that's sebaceous cell carcinoma, which is spreading intraepithelial, your pagetoid spread, okay? And those just appear as red eye patients who have seen 4 or 5 providers. No one's been able to cure them, and nobody stepped back and said, wait a minute, why do your eyes look so different, right? And they look, and that one's thickened, and that's because of a sebaceous cell, which has superficial spreading, okay? So even though most of the time we'll see the basal cell will be there, squamous cell, less common, but can also have that, that diffuse spread. We do see other types of things, other than sebaceous cell, melanoma and Merkel cell carcinoma would be the two more of the less common ones there, okay? So moving on to the conjunctiva, right? Specimen handling is crucial, right? And this is an example of how you should admit a conj specimen. So you want to have it flat. Conj is when you take off a pterygium or whatnot, and you pick it up, it just all crumples up, right? So we all have sterile instrument packs in the OR. Just put it on one of those things. If you don't have that, have them get your tongue blade. You could, cut part of it, have them break the tongue blade off. Put it flat on that. Let it dry for maybe 30 seconds or a minute or so, and you could drop it all in formalin with that paper or with the tongue blade in there. That'll keep it flat, because the key thing is, to keep it flat so we can interpret it. Once it crumples up, it's very hard. So we think of, okay, we're looking at this. I never give unknown cases when I teach the residents, but sometimes I'll have them just think about, well, what is it going on here? Well, this is conjunctiva, right? And you see in the stroma, there's some vascularization, and you've got solar elastosis. That's that purple, substance there. And there's loss of goblet cells. So this is a patient with a pterygium, okay? And so we say, well, do I need to submit it? I know it's a pterygium, and the answer to that is you should submit all of these, all the pterygium specimens. and I'll show you why in a minute. But so here's a patient who had a successful pterygium excision, and here's that patient 4 months later, right, in that area there. So we're very good at diagnosing pterygia. They look. There's not much that looks like them, but there are some mimickers. And this one, when we looked at it, the original one was not submitted, and this one was. And we look at higher power. This is clearly not vascularized. This is a spindle cell neoplasm, which was removed and grow back. So what's our differential here? Well, the most common one would be a squamous cell, a spindle cell variant of squamous cell. Melanomas can do that. This one happened to be a more rare leiomyosarcoma of the conjunctiva. But that's another reason why, even though it looks like something, you do want to submit the specimens, okay? Here are two other pterygium mimickers. These are both variants of squamous cell carcinoma of the conjunctiva. And the histopathology here, you can see the transition zone between the normal epithelium and the invasive squamous cell component, okay? So here are the exceptions that I think that you should that you might not need to send. The first Chalazion, right? I know half of our eyelid, oculoplastics people send all of their Chalazion. Half of them don't. I think they're both practicing well within the standard of care. So I think most people probably don't send Chalazion specimens, and I think that's fine. So, but if it's recurrent or atypical, I think 100% of those should be sent. Okay. Then the cosmetic, blepharoplasty specimens, we don't really those ones you don't need to send. And then, but I get asked the question, well, what about ptosis? We're doing a fascinella servante, we're just going to lift the lid up, and those ones, definitely yes, okay? Most of the time, you're going to get a report back that says muscle and fibroconnective tissue, right? But probably a couple times a year, we'll get a surprise result, and the most common ones being either a type of, a variant of lymphoma or some sort of metastatic, lesion there. So ptosis specimens, I would recommend that you send all of those ones, okay? So I'm trying to keep something for everyone here. So we're talking about orbital biopsies now, moving farther back. So I looked at our last 100 biopsies of the orbit. And here's what we found, neoplastic orbital biopsies tended to be most of the pathology here. Lymphoma being the most, a non-lymphomatous neoplasia followed by lymphoma, right? And then of the non-neoplastic, basically inflammatory versus non-inflammatory, okay? So what do we talk about in terms of looking at and biopsying orbital lesions? First of all, radiologists are your friend, okay? So meaning that we looked at all of these 100 biopsies and looked back at the radiology reports and how often did the radiologist, quote, get it right or include it on their differential, right? And so, over 70, close to 75% of the time, they included that on there. But going back to one of my initial points, we found they had a much higher correlation of giving you the right answer when the surgeons provided a differential diagnosis on their report, okay? So again, you're not gonna bias them, but if you put that on there, they'll eventually come up with the histopathologic diagnosis, a higher percentage of the time. And so we looked at, just basically, the lymphomatous ones, extramarginal, extranodal marginal zone lymphoma was by far the most common type of lymphoma we encountered in the orbit. Of the non-lymphomatous ones, okay, what do we run into? Interesting, so basal cell carcinoma, and if you look, squamous cell carcinoma, so extension of eyelid things into the orbit was by far the most common thing that we saw, followed by metastases, and then your primary ones, your primary orbital ones, like hemangiomas, schwannomas, and solitary fibrous tumors were farther down on the list, okay? So inflammatory lesions, lymphoid hyperplasia, sarcoid, those are probably the two most common things that we ran into of the inflammatory ones. And of the non-inflammatory ones, okay, so again, this brings back bad memories for a lot of people when you see a path slide with no history, right? We think of this, I won't call on anyone here, but what do we think in the diagnosis is here? Okay, well, doesn't look impressive. We don't really see many cells, right? And when we look at this, we'll do a special stain on that acellular area there. And if we're still not sure, I can put a polarized filter in front of there, and I see I'm demonstrating birefringence of whatever's under there. If I turn that polarized filter, it's two different colors. You get that apple green and the red, so dichroism there. So this is orbital amyloid, okay? And amyloidosis was one of the most common non-inflammatory ones that we ran into. And just to show you what I do when we look at past specimens, sometimes you have to find beauty wherever you happen to be, okay? And that's what I always think when I zoom out from here, it looks very similar to something like this, so. So of the non-inflammatory ones, amyloid was one of the most common ones, okay? And when we looked at the radiologist ones, basically when the radiologist missed the diagnosis, so to speak, or didn't leave it on there, amyloid was something that they didn't include. So if we suspect it, you let them know, and you'll get a bigger, a higher yield on your imaging studies. And I have to call out our poster over there from Texas A&M. As I walked in there, I saw a solitary fibrous tumor, right? Sometimes they will mix it up with a hemangioma because of the heterogeneous component in there and the cystic spaces in there. Communication does matter when you talk to us about frozen sections. Pathologists can give you the right diagnosis, 97% of the time. But when we looked at all of those 100 biopsies where there were frozen sections, the most common reasons why we didn't get it right is because it was amyloid, okay? Because amyloid, if you just do a frozen section, it looks just like fibroconnective tissue, like you missed whatever you were trying to give us. When you gave us a piece as a frozen, you didn't give it to us. We'll read it out as benign tissue sometimes. But so amyloid is there. I'm going to finish up just really briefly talking about intraocular things. Retinoblastoma, endophytic and exophytic, clinically, they look very, very different. Endophytic will grow inside the retina and exophytic underneath the retina. So exophytic would look more like a exudative retinal detachments, whereas the endophytic might look more like a uveitic thing. If you look on the bottom, the histopathology showing on the lower right is your optic nerve. The retina, you could see most of these are mixed, so the tumor is growing both above the retina and below the retina, okay? So looking at the histopathology, all of my residents know, they stand up and they say this: Eyelid's a blue tumor and a sea of pink necrosis with purple calcifications, okay? You can see your rosettes and your florets. And the high-risk characteristics that we look at are optic nerve invasion, okay? And here's up to the lamina cabrosa, and here's full thickness invasion, and if you look on either side, choroidal invasion. So those are the two high-risk histopathologic findings that we look at, is optic nerve and choroidal invasion. So you as a clinician, if when you do that, communicate and then basically tell us where the tumor is, okay, and then obviously we know to obtain a long section, but if you're going to go into the eye after it's enucleated to remove tumor, let us know, because that can artifactually spread into the choroid, which might then cause the oncologist to give that patient chemotherapy unnecessarily, because it's artifactual choroidal invasion, not real. So talk to us about how to do that. And then finally, uveal melanoma. The one thing I just wanted to tell you with this is that, when I was studying as a resident, we looked at cell type, spindle epithelioid, right? Our main predictors were tumor size, small, medium, large, and cell type, spindle mixed epithelioid. They match, about in terms of 5-year survival rates, is shown there. But now, we can do gene expression profiling and get a much better predictor of a metastatic risk, okay? So by looking at that. So you can do GEP by doing a biopsy, needle biopsy, or you can get it after enucleation and getting the GEP there. So, and those are just basically the genes that we look at when we look at gene expression profiling. And the question that I get often asked is, well, why should we do this? Well, it's up to the patient whether or not they want to do that. Do they want to know their risk? Now we have drugs and studies that are in production for metastatic uveal melanoma. So that's why GEP might be something that you might want to look at. And last thing is, if you do see any evidence of extraocular extension, please let us know, because when your eye is nucleated, oftentimes there's hemorrhage on the eye which turns brown, and you get all these brown spots. You don't know which could be extension versus dried blood. We're going to look at that area very, very closely. But so with that, I think I will stop here and entertain any questions.